I've never been more excited to do this than I am today. With us, we have Dr. Chris Frueh, the author of Operator Syndrome, and he's many more things, and I'm going to let him introduce himself. But he's also a part of the company, Sharp Performance, and we use a lot of the framework of Operator Syndrome and how we interact with our customers from a coaching methodology. So really special to have him here today, and looking forward to the conversation.
Thanks, Max. It's great to be here.
How you doing?
I'm good, man. This is exciting stuff, what we are doing with Sharp. I think it's going to change lives, change paradigms.
Just to give some context, we're actually here at our first big company offsite. We've grown massively in the last year and a half, and this is the first time we've gotten pretty much the entire team together, from our engineering team to our coaching team to our marketplace folks, and we're at a nice resort in Southern California, and Dr. Chris Frueh came down, so we're sitting in a hotel room right now, a little bit of a different setting in between our sessions this afternoon. But first, I want to start off by just, Doc, tell us who you are. Tell us a little bit about your professional background, and then we'll kind of keep going from there.
Okay. So I'm a clinical psychologist, earned my degree in 1992. I came from a childhood. My father and my great-grandfather, who died when I was 14, were both veterans and served in war theaters. My great-grandfather was at the Battle of San Juan Hill, 1898. He was kind of one of my childhood heroes. My father was a Vietnam veteran as a physician, Air Force. I wanted to work with veterans, and that's why I went to graduate school. Started in 1987. PTSD was a brand new diagnosis, so I had never even heard of it when I started graduate school. But I had an understanding from my childhood in the 1970s that, from both my father and my great-grandfather, the war affected soldiers in ways that were pretty profound. And those effects were often very lasting. And so I wanted to be a civilian support, I think. I've never served myself in the armed forces, but I wanted to give back and support. So I spent 15 years at a medical school, a medical university of South Carolina in Charleston. And I had a full-time job at the VA there for 7 years as a clinician, frontline clinician in a PTSD clinic. Loved it, loved the work, loved the patients, had great colleagues. After about 7 years, I was into my career. I was encouraged to apply for research grants. And so I did. It was kind of a lark for me, not an ambition, not something I really thought of myself doing. I never had gravitated towards research, but just through my curiosity of the patients we had coming through our clinic, we started writing and publishing some papers. And then I had a mentor who said, you really should submit a grant. To my surprise, it got funded. And then that kind of veered me off a little bit into a slightly different path. I became a sort of a 75% research, 25% clinical. And I did that for the next 8 years. And my research was relevant to my clinical work. So they really informed each other.
Right.
I left VA in 2006 and joined the University of Hawai'i, the Hilo branch on the Big Island, and I've been there for almost 20 years now. During those 20 years, I spent 12 years commuting monthly to Houston, Texas, where I had a faculty appointment at Baylor College of Medicine. I was research director at the Menninger Clinic, a private psychiatric hospital. And then University of Texas Medical School hired me to set up a center for veterans, mental health care and research. Grants, research publications, but always kind of clinically focused and minded.
Right. So how many years is that total since when you first started with the veteran community to now?
Well, if you count my dissertation work, which while I was still a student, 35 years.
Thank you. Thank you so much for being such a steward to our community.
It's been my honor, my privilege. I've been so blessed to be able to have the work and that I've been able to have.
For everybody listening, and we're going to get into it, but the reason why this is so close to my heart is, right when I was leaving the SEAL teams, I was introduced to the PDF version of Operation before it was a book. And it really was the thing that I read that set me down a different path. Right.
It was a medical paper. We published it in the peer review medical journal,
right,
2020.
And it got shared within all our, the back end WhatsApp things like, hey, you have to read this. It's different.
It went viral in the grassroots operator community, which is unheard of in science. We don't write papers for the people we're studying.
That's so interesting.
We write papers for other scientists, other clinicians. That was really an unusual phenomenon that occurred. And I kind of watched it in real time because all my contacts on LinkedIn at the time were operators.
That's the power of the community, right? One of the earliest phrases you learn when you show up is called pass the word. If an instructor will come by and whisper something in someone's ear, seeing if that person has the ability to then share that, so everybody has to be attentive to, what you're being told in your environment. And I think that carries true throughout your time in the organization. And when you're a part of a tribe, when you care so deeply about the people you work with, when somebody introduces a piece of work, a tool, a piece of gear that's going to help the organization, it very quickly gets shared. So I was so grateful to be able to read that.
It's an incredible community.
Yeah.
I've seen that over and over and over again over the last 12 years or so.
So tell me about the path, not only the realizations that you came to working within the VA and doing research, but talk about the progression of where your mind was from being, obviously, learning in a university setting and getting your PhD, then becoming who you are today. And then where does that shift happen where you're like, I don't think that this is the way anymore?
Well, I'm going to say the shift happened probably in the mid-90s in some ways. I was not working with operators. I never met an operator when I was working in the VA. Literally, I think the closest, there was one. There was a Vietnam veteran who had been Marine Force Recon, and he was legitimate. And he had done 2 tours, and I worked with him for several years. I left the VA in part because I could see what I perceived to be the VA's policies at the central office level. Some of the way we did things at the local and regional levels were really flawed and in many ways tragic. It still is. I think we've encouraged veterans to become psychiatric invalids by grossly over-medicating. 15 different medications is not unusual, which is madness. It's just madness. And it's destroying people. It's destroying veterans. The wait lists, the bureaucratic inertia, the disability policies themselves, encouraging people to be sick and not well. A very common experience I had in my clinical days at the VA were patients who would say to me, hey, at some point in therapy, this doc, this has been great. This is really helpful, but please don't write that in my medical record because I don't want to risk losing my disability, which I understand. That's a rational, they're rational actors. So we as a nation have created these very large incentives to stay sick. Civilians with PTSD typically get better quickly. I worked, one of my research projects was working about 25 years ago was a project that we did in the community mental health system of South Carolina. And so the patients were diagnosed with some form of severe mental illness. SMI is the acronym. Most of them had schizophrenia. Well, we found they also had extensive severe trauma histories, and many had PTSD symptoms or full-blown PTSD. And what amazed me was they responded to the treatments we were doing with veterans really well.
Right.
Everybody said, no, you can't treat patients with schizophrenia. You'll make them worse if you try to talk about their trauma. That was the prevailing wisdom at the time, and I suspect it still largely still is, but it's wrong. We could treat them, and what we found was they were super appreciative that somebody was finally willing to listen and talk to them about their traumas. So that was really eye-opening for me to see. I treated a woman, mid-50s, schizophrenia, just one of the worst traumatic histories you could imagine. Sexually assaulted by her father from about age 6 on, sexually assaulted and beaten by two husbands, kidnapped and gang raped twice, not once, but twice, kidnapped and thrown in the trunk of a car, and listened to them talk about how they were going to murder her and many other things. And I started therapy with her with actually, even myself, low expectation. And about 8 sessions, she was notably different, notably better. And she was surprised herself. She's like, why didn't I ever receive anything kind of care like this before? And that really kind of began to change the way I looked at the veterans I was working with as well. Like, I'm not seeing that kind of response. But part of that is, I think many of them didn't really have PTSD per se. They were encouraged to kind of give some of the list of symptoms in order to receive the disability, but they also had incentives not to maybe engage in therapy or to engage in change, but also they were heavily medicated in ways that I think prevented them from improving.
Right.
Yeah. So if we fast forward so I left the VA in 06, and about 6, 8, 7 years went by, and I didn't really do much work with veterans. Probably have some publications where I was co-authoring with other colleagues, but not directly. I involved myself. And when I was working in Houston, this was going back about 12, 13 years ago now, I found myself interacting with a kind of a network, a circle of soldiers who came from special operations. And they had set up like a monthly happy hour social thing for themselves. And they came from all branches. And I'm thinking back, there were probably about 5 guys initially that I really connected with kind of right off the bat. One was a Navy SEAL who had just, like the year before, left DevGru, left service out of DevGru. And one was somebody who'd been a Green Beret and then served in one of the tier units at Bragg. There was a CIA and Intel paramilitary guy who had embedded with special operations teams units in Afghanistan and Iraq. They all said kind of the same thing to start with, which was essentially this. Something's wrong, and I can't put my finger on it. I don't know what it is, but I'm not right. I'm not well. Even to the point where I don't feel good, I can't function good, I don't want to work out, I don't want to have sex, I don't want to do the things I used to do. I don't want to, I just don't enjoy those things anymore. And I even look in the mirror and I don't look the same. I look different. One guy described to me, he says, I didn't used to have like a puffy, jowly face. I had sharp angular lines on my chin and more muscle definition.
Right.
And so this was kind of mysterious to me. In mental health care, and as I said, I've been in 3 psychiatry departments, which are large. They're multidisciplinary. You have geneticists, you have neuroimagers, you have internal medicine docs. You've got a variety of different specialists, but we never do I ever have any awareness of having a colleague who was had any expertise in hormones. No urologist, endocrinologist, andrologist, never. When I worked at VA, never once did I ask for a hormone panel on any of our patients. I mean, I was part of a team that included a psychiatrist, so it wasn't just me. I can say none of us asked for hormone panels. Right. Not even once that I can recall in the 90s and early 2000s. As I was having these conversations with guys who were really just kind of becoming friends of mine, and these were just pretty organic conversations. I wasn't writing notes. I wasn't keeping records. I wasn't submitting anything. I didn't report to VA. I didn't report to DOD. As I was starting to meet guys that were active duty, they could talk to me because I had no fitness for duty requirements or mandates or anything. I could keep everything could be truly confidential. And because I didn't keep notes.
You were just being a good guy.
I was just listening.
You're being a good guy.
I was just having conversations.
Right.
And as then it became, there were about, 6, 8, 12 weeks. It was probably 6, 8 weeks in to these first conversations. I was like, you know what? Something is missing here. What is it? And started getting more testing done. I had the ability to do some of that myself through my research programs. So got brain scans did MRIs on their brains. Showed those brain scans to a buddy of mine, a good colleague who was a neurologist. And I didn't tell him what he was looking at. These are just brains. Tell me what you see. And he said, well, no gross pathology, no white spaces, no lesions that jump out, no tumors, but the ventricles are pretty atrophied. He said, so I'd say these are probably elderly geriatric men, 80-year-olds. No, brother, this guy's 37. This guy's 40. And his jaw was kind of like, what?
Right.
Got blood panels on them, specifically hormones early on. And it came back, every single one of them had the testosterone of an 80-year-old man. Levels were so low. And I had to go actually do a little reading at that point to say, well, what does that even mean? I'm like, I know, testosterone matters. It's about your sex drive and muscles, but it's much more than that. A young man with low testosterone is going to look depressed. He's going to have low energy, insomnia, poor concentration, low motivation. He's going to be disinterested in things. He's not going to want to work out. If he does try to work out, he's not going to be able to do what he once did.
Right.
If it lasts long enough, it starts to do things like decrease bone density. So some of the orthopedic injuries I was hearing about, I started to wonder, I wonder if that's a contributing factor. Yeah, thank you. And so, and then sleep studies, that was the other thing. They all came back with sleep apnea. Why does a young, relatively fit guy, some of them were very fit, why would they have sleep apnea? I think I at the time thought of sleep apnea as something that you see in older men who are overweight.
Sure.
So now I'm going, wait a minute. All these guys that I'm talking to, they have brains, testosterone levels, and sleep quality of elderly men. And some of them looked aged. So now I'm like, okay. And here's the other piece. There were our conversations cover a lot of ground. There's no doubt, that soldiers, including operators, affected psychologically by their experiences. But it isn't what we assume. It isn't necessarily, what I didn't see was the fear reactivity that we used to expect as part of PTSD. That's kind of been, the diagnosis itself has evolved since 1980. The fear reactivity and the avoidance have kind of been minimized. So I think we can talk about this, but the diagnosis of PTSD has changed significantly since 1980.
To define that a little bit, the way that it was described to me, because we work with a lot of first responders, and it's the same, right, between the two communities. We came to these realizations with operators, but by symptom, it's very similar. And the way that was described to me is like, this cop necessarily isn't feeling fear about getting in the cop car to go do the job.
Correct.
The fear lives at home after the job is done, where most people who have complex PTSD, the fear lives with the actual experience. Is that correct way to describe?
Yeah. The original concept of PTSD was that it was classified as an anxiety disorder originally. In 2013, in the DSM-5, they moved it out of the anxiety disorders. They gave it its own new category. But the way I was taught, the way we originally conceptualized it was not just an anxiety disorder, but it was very focused on the specific traumas. And then when there was a reminder of that trauma, we use the word cue, trauma cues now. Sometimes triggers is the more popular word today. The idea is you as a soldier, helicopter flies overhead, and it reminds you of your war experience, and you have a physiological anxiety. Flashback, yep. You have a physiological response of fear and anxiety, and part of what you do is you escape that, and then you avoid it. So, the helicopters are over this road over here, I'll stay away from there.
Right.
The idea of, I don't want to shoot guns because guns remind me of the military. That kind of stuff. So, and this is something that's kind of a natural response.
Right.
If I'm afraid of simple phobias, if I'm afraid of snakes, I'm going to do everything I can to avoid snakes. I'm not going to go hiking in the Arizona desert. I'm going to do a little research on where I live and what are the snake risks here, and I'm going to avoid that. Right. And that avoidance is what then maintains the anxiety, because you never face it and you never get past it. and it's an easy thing to treat. We call it exposure therapy. If you're afraid of snakes, if you have a snake phobia, you and I are going to spend a lot of time talking about snakes, educating you about snakes, exposing you to snakes. I might even go get some safe, non-poisonous snakes and bring them in and drape them on you.
Right.
And you're going to go, you're going to be, you're going to have an anxiety experience. And then you're going to sit there with that snake crawling all over you for an hour or two, and gradually your anxiety will come down.
Sure.
And we do that 6, 8 times, 10 times, and pretty soon your anxiety isn't peaking and it's going down quicker. And then you get to a point where the anxiety is actually not there at all. That woman who I described who had been gang raped, we did the form of therapy with this called exposure therapy. We wrote out exactly what happened. And it made her sick, physically sick, to talk about it. She vomited. But about the 8th, 9th session, as we were just repetitively going through this, and we recorded our sessions on tape, and she would listen to those tapes on her own in between homework assignments. She actually said, Doc, this is boring. This is getting boring. I'm tired of this. Can we do something else? And I was like, yeah, high five. We're there.
Mission success, yeah.
Yeah. So that was the original concept of PTSD. I saw no fear reactivity in the operators I was working with. The firefighters, the police I work with, other veterans from other elements of the combat arms. I don't see the fear reactivity typically. I mean, sometimes it's there, but that's not very, not always. I mean, not usually. My field, the mental health field, has an unfortunate response to that, because now everybody's taught, a soldier who deployed to a war zone must have PTSD. We assume it now.
Right.
It's assumed. And so if you deny that fear reactivity, if you deny that avoidance, there's a really good chance you'll be told, well, you're in denial. And the fact that you're denying it is proof that you have it. So it's like the old Salem witch thing where they throw the suspected witch into the water, and if she drowned, she was innocent. She wasn't a witch. But if she floats, then she's a witch and we hang her or burn her.
Right.
That's probably a little over the top. But so I wasn't seeing the anxiety, the fear reactivity, the avoidance. So as my guys started to feel better, function better, have better relationships, get their professional post-career life in order, their jobs, their employments started to do better. And they were grateful and appreciative. And many of those guys are still good friends of mine today. Worked with them on projects. They stay at my house. I've been to their homes. I've been to a funeral, weddings, birthday parties, retirement ceremonies over the years. So I actually really get to know a lot of the guys I've worked with. And then something unexpected happened. After probably about 6 months into this, other guys were being introduced to me. Hey, and it was just simply word of mouth. Hey, you help me. Would you talk to my friend from the unit? Sure. And that's just snowballed.
So what I'm hearing is trust, right? Something that's different between what we do with coaching and classic kind of clinical therapy is there's not a real relationship with the human being. I am very much into the idea that to trust what a person is saying, you have to get to know the person, and you're taking time to actually get to know these guys, in their personal lives, their spouses, you're going to birthdays. How big of an impact is having a real relationship with a person from, say, like a coaching perspective versus, kind of classic clinical psychology where you're just a person in a room who has all the credentials to speak, but there's not a whole lot of human relationship.
Well, traditional therapy is typically a 50-minute session, sometimes longer, and usually once a week, once a month. Psychoanalysis, it's more like 3 times a week, supposed to be. But it's sort of 50 minutes, maybe it's 45, and then the bell rings and you're done for that session. I mean, there are great therapists out there, don't get me wrong. And that model works for some people. Coaching, I think I've become a fan of coaching probably for about the last 6-8 years or so, because I've seen it be much more personable, and coaches have a chance, especially the way Sharp does it, where the coaches come from the communities, the military, the first responders communities. So they've been there, they've had the difficulties themselves, they can relate. And oftentimes, I think, use their own story, share it, and talk about it. which I myself, commonly do now.
Yeah.
And by the way, I was not doing therapy. If I look back on it now, I would say it was coaching.
Right.
At a very personal level. And so I would do that when I was in Houston, and when I was home in Hawaii, it was phone calls. And I hit a point somewhere after about a year where I was having 4 to 6 phone calls every day, often weekends. Sometimes they were short, sometimes they were long, sometimes they were last minute, sometimes they were scheduled in advance. I wasn't charging, so it was, nobody had to pay anything, and I wasn't billing insurance, so there was no records that I was keeping. I was just having phone calls, conversations, and learning. I was learning a lot. And if we come to this point today, I would say, just to kind of summarize my experience a little bit, I've probably directly worked with probably 300 operators directly on my own. I've evaluated and coached probably about 300 private defense contractors, and I was paid for that work through a law firm that paid me a little bit to do one thing, but I didn't just stop at that. I felt like they needed more than what they were getting. And many private defense contractors come from law enforcement, the military, special operations, but not all. I probably worked with about 50 individuals who were Iraqi or Afghani, embedded with our troops as interpreters, cultural liaisons, soldiers, allied forces. I also, some of the private defense contractors were HVAC technicians or logistics or HR. So not all of them were even soldiers. They were people who signed up and took a contract and went and found themselves working on a FOB in Afghanistan with very little military preparation for that. And then so we published our paper in 2020, the medical paper, titled Operator Syndrome. And at that point, then there was a name, then there was a terminology. And just to quickly say, the concept of operator syndrome is very much physiological. And it's about how the physiological affects human emotions, behaviors, relationships, cognitive functioning, emotional functioning. It's a constellation of injuries that are all interrelated.
Right.
So it's brain injuries, it's effects on hormones, sleep, joint pain, headaches, cognitive functioning, poor concentration, short-term memory impairments.
Reactivity.
Emotional reactivity. I mean, the emotional stuff, I'm not going to say PTSD is not there at all. It's a part of it for some, but more prominent, I would say, are depression and anger and general anxiety, panic attacks for no apparent reason for some people. But also now very clear evidence of cardiometabolic functioning, dysfunction. So gut, heart, sensory systems are affected, vision, hearing, balance. A lot of guys have vertigo, which is a mixture of TBI and anxiety and some of the other things. And then you get into the existential and the relationships. You can't have all that physical burden on you. And by the way, we have a theoretical phrase called allostatic load. And we can come back and talk about kind of the vectors. But allostatic load is a hypothetical concept. We don't measure it directly or specifically, but it's a way of talking about all that is on top of you, all the burden on you. The rucking, the jumping, the diving, the constant high op tempo that elevates cortisol hormone and other stress hormones round the clock for years at a time. The sleep deprivation, all of that is allostatic load. The blast exposures, and that's another topic we could talk about. The repetitive blast exposures, which 10 years ago, we didn't understand much at all.
Sure.
We really didn't understand much at all what that did. So the existential issues are often profound. They're not what a lot of mental health professionals expect or assume. We've put words out there: survivor's guilt, moral injury, but there's not really a one size fits all.
Right.
I have my own, I'll just call it moral injury, which is a sense of betrayal by our government, our flag officers, our politicians in the way we pulled out of Afghanistan.
Sure.
I've been working with Afghanistan veterans. I've been working with Afghanis themselves. In the 2 months prior to our pullout, I've been having direct coaching interactions with 4 men, and almost by extension their families, who are still in Kabul.
Yeah.
And they were telling me what's going to happen. Listen, your government's going to leave. One guy took me over to the window with his, with his compute laptop.
Right.
We were on Zoom, and he was showing me that's a Taliban checkpoint right down the road. I can see it from my house. Your government, your State Department is refusing to see it or acknowledge it.
Right.
They're here already. And they're already in town. They're already setting up checkpoints and harassing people. And then, of course, after we pulled out, I lost comms with those guys, and that hurt. And I can tell you, my little opportunity of karma to kind of get a little bit of do a little bit. It was part of an effort to bring a lot of Afghanis out of Afghanistan in the last few years. So it's a profound mix of physiological, psychological, and I'm going to say spiritual, or spiritual, soul, metaphysical, whatever words you want to put onto it. So it's complicated.
Right.
And modern medicine is very fragmented. If you see a urologist, they're not thinking about all the other things. You see a psychologist, they're not thinking about everything on that list. And so we failed the generation of GWAT veterans. I really believe that. And that's on us, because we haven't been listening as a field.
Isn't it interesting that from the beginning of time, right, of call it modern medicine, that we're willing to change the chemistry of the human body and mind with medication without having a baseline of where the body stands, right?
Without fully understanding.
We're looking at symptoms, and we're injecting chemicals, and we're not having a full understanding. My own personal experiences, right? Traumatic brain injury, Vyvanse to wake up. You
got the combat cocktail.
A beta blocker maybe during the day, a Xanax at night, intensify it with a little bit of alcohol and
something to help you sleep, probably a few antidepressants in there, and pretty soon it's the full combat cocktail, bucket of medications.
Right, because you're convinced that this is just the way it is, right?
Yeah.
This is just how I'm supposed to feel. I chose to have it's a voluntary program, right? No one is told they have to be a cop or a firefighter or a SEAL.
Right.
So you take on that idea that, like, I volunteer for this, and this is the repercussions of doing the job, and there's no other way to go about it, right?
Right. And if you don't have a name for a problem, how do you find the solutions?
Right.
I think, and then we could, when I think about first responders, I see all of these things. You see all of these things, including
almost worse in some cases.
Most. One of the big differences, just to put it out there, is you fought your war overseas, thousands of miles from home. So when you came home, your home, at least in theory, was a sanctuary that was removed from war. Whereas first responders, their battle is in the streets of their hometown, of their neighborhood.
Right.
Maybe even people they know that they're responding to. And every call is somebody's worst day.
Yep.
I don't call 911 on my good days. I've never called 911, but if I do, it's because it's a pretty bad moment in my life. And those responders who show up, I'm not in a state to thank them and in that moment. So they're not getting a whole lot of gratitude or appreciation. And then you add on top of that, we as a society have kind of denigrated our first responders.
Right.
And I would compare that to the moral injury or the betrayal of institutional betrayal that a lot of soldiers felt at the way we pulled out of Afghanistan, or the way we mandated a vaccine that was still experimental, or the way we've promoted certain ideas and people based on demographic, fixed variables of gender, skin color, sexual orientation, et cetera, et cetera.
I've had to talk with a lot of different Border Patrol personnel, but one thing that really struck me, because I never thought about it like this, and they made a relationship to pulling out of Afghanistan. They said, I've spent the last 20 years protecting the border, and in the last 2 years, I saw every bit of work that I dedicated my life to go down the drain.
Yeah.
And I don't talk about, politics in any way, but just thinking from that person's perspective, like them watching their life's work and how many times they put their life on the line, and how many times they had interactions with the cartel, and that, it
was almost sort of like, never mind.
Right. And then you think about that in terms of cops and firefighters. You do it so many times that the compassion fatigue is real, right? The suffering person, the child, the family. If you don't have the tools to check in with yourself and understand, what's going on in the brain and body, it becomes such a repetition that the realization of that particular traumatic event just doesn't really exist. It's a hard environment.
It's called habituation.
Right.
We can habituate to pretty much anything if we experience it over and over and over again. And it's actually, it's at least partially physiological. You hear the air conditioning humming right now?
I do.
Because I pointed it out. Were you listening to it and attuning to it?
No.
Before I mentioned it? Yeah, nor was I. If it shuts off abruptly, we'll notice that change, and then we'll habituate to the new level of ambient noise.
Right.
Until it turns back on again. And if it does that often enough, we stop even noticing that very much.
Right.
Movements. We have peripheral vision for a reason. We can focus on what's in front of us. If there's a movement over here, that we can then orient to that. So we do habituate to things that are, difficult.
Good and bad things.
Good and bad things, right. Right.
So with what you've seen, right, with all the research you've done and what you know, like, why did you join the Sharp Performance team? What are we doing that's different? And, what do you think the future looks like in this work?
When Andrew Sackmar first approached me, which was probably a little over a year ago, I'm not certain of this, but I think it was October of 24. I probably get approached about once a week now.
Right.
By somebody who has a product they want to sell, a startup business, a foundation, and sometimes they are looking to sell me or persuade me that what they have is a good solution and they want me to be aware of it so I can represent it out to other people.
Right.
Sometimes they want me I get asked to be an ambassador a lot of the time, or an advisor. I get burned a lot, or I've become very cynical about a lot of the approaches. I still try to say yes to most of those approaches because you never know. You never know when you're going to hit the jackpot. I hit the jackpot with Seal Future Foundation about 4 years ago, an amazing nonprofit.
So did I. I've received so much help from them.
Yeah. Joey Fio, who runs the health program, who, by the way, would be an amazing interview.
Yeah, I would love to.
And they built their health program for SEALs, and it's a peer coaching program that includes health advising. And of course, they will kind of talk with SEALs about options for care, and they'll pay for it. And we have a referral network and that sort of thing. That was amazing. Most of the approaches I get are either just ill-conceived, oftentimes very well-intentioned, but I don't see the feasibility of them working out.
Right.
Some of them are, I don't feel good about. Some of them I'm not sure, how, what the integrity is. I think when Andrew Sackmar first reached out to me, we had a conversation. I was like, this was a good conversation. I like this guy. He had the right attitude, the concept of operators providing coaching to first responders and other soldiers, other high-risk professionals. That's a concept I already believed in.
Right.
I was already sold on I've thought about that concept before, in part because I've seen it with Seal Future Foundation in a different way, a very different kind of way than what Sharp is now doing. And then I asked around, I have a network. And so I put the word out to my network. Who is this guy? Is he trustworthy? Is he respected? And then I met you. I met Steve Bunting. I met Brendan Dowling. And so in asking around, everybody's like, oh yeah, that guy's a prince. That guy has a sterling reputation. Brendan, somebody said to me, Brendan is somebody who I know well and trust and believe in, said to me, Brendan is the most humble DevGru operator out there ever. There's a lot of humble DevGru operators.
You should have saw me trying to interview him on a podcast.
Truly humble.
Yeah, he is.
Steve Bunting, 5 minutes into meeting Steve, I was like, this dude's a fucking Zen master.
He was born to do this.
Yeah, he was born for this.
He was absolutely born.
So then I was ready for the second conversation. I don't remember the exact chronological order, but I think you guys invited me to join you out in Utah. We presented and met with. We spent several days with a special forces group out there in early February of this year, 25. So I got to spend 3 days, breakfast, lunches, dinners, driving, presenting together, sitting in a room together. At the end of that, I was like, I'm all in. Sign me up. Where's my contract? I want to join. I was and continue to be not just impressed, but just like I have goosebumps right now just thinking about what we're doing together. And it's just, I think, already so impactful. And so, I mean, I'm a small part-time role, but I hope my role will continue to grow with Sharp. Later that month, I was out in Wisconsin. Later in February, I was out in Wisconsin with you and Ben Curley, Drew Connor, Justin, some of the other guys, Chris Reese, and that was another amazing experience. And at that point, you guys had already been working with some of the firefighters in Wisconsin by that time. So after you and I did a workshop together, and it was our second workshop together that you and I did together, and we've now done 3, firefighters started to come up to me. And I'd already been working with firefighters, written a piece called Firefighter Syndrome, which is really just the same operator syndrome mapped onto firefighters. Probably 30 guys came up to me later in the day as we were at this 2-day conference to shake my hand and thank me and to say, man, you just described me, you described my life, you described what I experienced, and I thought I was the only one. I was like, yeah, I get it, because that's what I hear all the time from the operators I've worked with. Then there was one day there, I don't know if I ever even shared this with you. I was the breakfast room had these long tables set up, so you didn't like sit at your own table. You didn't sit at a with your own group. So I was in there one morning eating breakfast all by myself, but there were, I think, 4 or 5 other battalion chiefs at the table and fire chiefs, and so I was just overhearing their conversation and what they were saying. And one or two of them were already receiving coaching services and were saying to the other chiefs at the table, this is transformative.
Right.
Here's the ways it's benefited my men and myself. And that was the day before I presented. So they didn't know who I was. I was just some random dude sitting down the table from them, which made it even more cool. We were out in Arkansas together, you and I and a few of the other guys, and we presented to probably about 140 law enforcement.
Yeah, DEA, local, state,
SWAT.
Yeah, SWAT.
State police, sheriffs. The sheriff of Pulaski County was there. And that, again, the same response, the same reception. And, I made friends with those guys, and I've stayed in touch with some of the leaders of that. And I think I'll be back out there. They've asked if I would come back out there, for a health leadership summit kind of thing, and then, coming soon. And I think I know you and Drew have been out there several times since we were there, and they want to do the research to really look at this as it applies to police in Arkansas. And so that's really exciting for me.
Arkansas DPS are going to be the real movers and shakers of law enforcement. I can see it right now. They are taking this so seriously, and there's 7-10 other states who are recognizing what Arkansas DPS is doing, the levels they're willing to go to really run a high quality clinical study on not only hormones and blood and saliva, looking at things like cortisol, but also the effects of coaching, right? And we're going to be involved with
the
that.
Outcomes.
And
outcomes of the coaching.
The outcomes, right. And I couldn't be more excited. I think it's going to be something that really starts a movement. And honestly, it all kind of started with you. So
I want to be really clear. This isn't me. It's certainly not all me. I've had many great colleagues and fellow travelers along the way. And that's something else that started to happen is, I met along the way this Jeff Dardia who was a Green Beret. He just retired earlier this year, created Task Force Dagger. And a few years ago, maybe 5 years ago, I met him and came to learn he and I have been doing some of the same kinds of thinking for quite a few years. He didn't necessarily use the exact same terms or all the same issues that I was looking at, but he was doing stuff with hormones and all, many of these issues going back, 10 years. And he was doing it as an active duty soldier at Fort Bragg, where, I know he was taking hits and arrows for what he was doing because it was so different and so outside the mainstream understanding of things then. I met the psychologist at Development Group at one point. I actually went out to Virginia Beach and spent a couple of days with Joe Bonvie and George Steffian, and I sat at the table with them and had conversations with the whole team, and I was really impressed. I mean, I very impressed. Now, I've also been back there at other times and met other groups of mental health care professionals that didn't impress me at all. So I don't want to say just because you're a psych at the Def Group or Group 10 or Group 3 that you're going to be an amazing clinician, but there are amazing clinicians. So there were fellow travelers, and I learned from them. I would say George Steffian, Joe Bonvie, Jeff Dardia, Brian Stepanenko, an MD at Bragg. These guys, I got mentorship from them. I learned a lot from them. Karen Kelly, a physiologist out at Coronado, working with SEALs and Marines. She was just doing purely physiological work, very much about stress hormones, testosterone, other things. And so I went out and spent a day with her at her lab and learning from her. She later became a co-author on the operator syndrome paper. Marcus Luttrell, former Navy SEAL, now soon to be former U.S. Congressman. When I met him, probably 2017 or 18, he was working on a PhD in neuroscience at UT Dallas. So we started having conversations. So, the paper we published really was a true group team effort, and there were many people who weren't authors on that paper who had profound impacts on it. And now that I've said all of this, I'm realizing there's a lot of people I haven't even, given credit to. Sean Rosario with Warrior Health Foundation, early on conversations about hormones. Ken Falk and Josh Goldberg at Boulder Crest Foundation. They created a whole peer program, not coaching, but a peer program.
Yeah, they work with a lot of law enforcement. We hear their names, especially in Arizona.
Yes.
Chief at Tucson PD.
Yes.
He has a really strong alliance with Boulder Crest. We've heard amazing things.
I was on their board of advisors for a good number of years. I've been to some of their programming, and they serve veterans and first responders. There's no direct touch from anybody with an MD, PhD, social work degree, nursing degree. It's all, we're in the background, but we're not there doing any of the services directly. It's all peer-to-peer. There's one of the things SEAL Future Foundation has, and we set this up as we were building the health program, is we developed a committee or a health advisory board, which I chair, and I've chaired for 4 years. It's multidisciplinary. We had John Pasiak, who's a former Ranger. Now he's a PharmD working in VA. Yeah. Rebecca Ivory, Jen Byrne, whose husband is an active duty. She's an OT. Her husband's an active duty PJ.
Yeah.
Warrior Foundation. That's another really good one. Got to know them a little bit. Sean Mulvaney, who was a SEAL, went to medical school, pioneered stellate, one of the pioneers, not the, but one of the important pioneers of stellate ganglion block therapy. He's on the committee. Kevin Lace, a SEAL, he's a PA. Kirk Parsley, SEAL, MD. He's been working for, probably decades on hormones and sleep and things like that. In his mind, I think he was thinking of it as SEAL syndrome all this time. But so what started to happen about 10 years ago, as I was sort of learning, is I found there are all these fellow travelers out there, each kind of chipping away in their niches, and the dots started connecting among us at some point. And I'm going to just apologize. I've left out names.
No, I think the point is that if you want to make real change in your community, it's got to come from within. You can take the best information in the world, right? I got to talk to a psychologist early on. I won't name her name because I don't know if she wants to be named, but she worked with NSW, and she said, Max, the hardest part about what I do is getting people to invite me in the room. Yeah. She said, I have PhDs from those prestigious schools, you can get it from. I've done the greatest research. I'm revered in all these communities, and you guys look at me like I'm a school nurse. Said, you're not a professional until you get invited into the room to be one, is what she said to me. And that kind of really put me back on my heels. I'm like, that's so interesting. She said, the work that you've done is that you've earned trust. You've earned trust enough that it's excited people to then go on their own exploration to see what problems they can solve. I mean, there are so many guys from, the CO Green Beret Ranger community that became PAs, PhDs, LMFTs, any number of things because they saw how important it was. They weren't going to let somebody else help the community that they cared about.
Started foundations.
Right. We're tired of waiting.
Explored psychedelic medications.
And all I can tell the first responder community is that the hard legwork has been done. Like, come talk to us about it. Like, it's all we care about. We live it. You don't need to recreate a peer support or wellness program from the ground up anymore.
Yeah.
A countless number of lives have been lost. Lessons have been learned so that you don't have to do this stuff, right? We're very lucky to be able to work with you and the people that you've worked with. And if we can do anything, it's just spread that message. Of course, we want to work with you, right? In a business sense, we want to be working with every law enforcement agency, fire department in the United States. But if we can start a conversation with a really good foundation of well-vetted information instead of creating something out of thin air, like you've already done the trials and errors, there's no reason to do it again.
And I guess to tack on to that is, I sort of, in my head for years was thinking operator syndrome. But that's because I was working with operators. And operators are at a very extreme end of that allostatic load, partly because of the intensity of the work, which, by the way, is it's not the combat deployments per se. It's also heavily the training, which is very intensive. And it's the nonstop, go without recovery breaks. And it's the length of a career. So a typical infantry soldier might have a lengthy career, but many do want a 4-year enlistment and then they're out. Operators tend to go as long as they can, which is often 10, 12, 20, 30 years. And first responders are typically a full career of 20, 25, 30
Right.
careers frequently. So it's not just about what happened in the last month or week or day. It's what's been happening and experiencing for years and decades.
What I get them to come to realization, I do an exercise where I'm talking to a group of firefighters in the room and I say, I want you to think about the last time you went on vacation, right? And really think about how long it took you to get to a mental and physical place where you felt like you were on vacation, where you were really enjoying the moment, where you didn't have to force, early in the day alcohol consumption to get your nervous system to relax, right? To reduce some of that, surface allostatic load. It takes about 3 days, right? For every person raise their hand, about day 3, I finally exhale like, holy cow. It's like, okay, now put yourself back into the real world and think if 1 or 2 days off is enough time to really deregulate, to really control the nervous system and the mind, or are we so good at compartmentalizing that moment that we're tricking ourselves to believe that we're relaxed for a couple of days, where what you're feeling while you're at home is just as high intensity as when you're at work. You're still living that same thing from a chemical level. And if we can get you to build process around that, to become very conscious of what those things are that you're seeing, feeling, experiencing, and shut it off, even for a couple hours at a time, the effect that can have on the brain and body, and giving you a true moment to reset. And coaching doesn't need to be, this big woo-woo moment where you got to talk with someone for multiple hours. It's like, let's get control of the breath. Let's get control of the mind to just give you a moment, right? And tap into that. And I think that's something that we've learned.
I'll share my own personal experience. I was kind of a ne'er-do-well in graduate school. Professors didn't have a whole lot of expectation for me, and I don't blame them. I met a woman who was a class ahead of me in graduate school and became close with her, and we're still together almost 40 years later. I don't know how she did it, putting up with me all those years. through the 90s, we never took a vacation. We just worked and we worked and we worked. And I think we took our honeymoon circa 1999 after we'd already been together for 12 or 13 years. And it was cool. But at the end of it, we got home and we were so stressed out because of all the emails, all the assignments, all the tasks that hadn't been done in the last week.
Right.
And we both were like, man, vacation, it might not be worth it. Because and in part, during vacation, I was answering phone calls, I was answering emails, and we went out, we flew off to Maui, and it was great, but it wasn't. I can look back and realize we didn't really disconnect. And then when I moved to the University of Hawai'i in 2006, something interesting happened. So I arrived. My pay date started August 1st. I arrived July 31st. Went into work, reported to work the next day. Literally, we arrived probably late in the day on the 31st, slept on the floor because there was no furniture, went into work the next day, here, ready to go. Where's my office? Where's my desk? And I was literally told, like, this is Hawaii, right? They're like, classes don't start for 3 weeks. We're not ready with your office. We don't even have a desk for you. Check back in 2 weeks. And we'll do an orientation thing in a couple of weeks. I had 2 weeks with nothing on my plate for the first time in my adult life. 2 weeks. I had no to-do list. I had emails from, colleagues and things and projects I was working on, but it was minimal. And so I was going to bed at night and getting up in the morning with no thought of today I got to do X, Y, and Z and A, B, and C. And I was used to 5-6 hours of sleep at night. And once we got a bed set up, those first 2 weeks, after a few days, I started sleeping 12 hours. I was like, this is weird. Why am I sleeping for 12 hours?
You're exhausted, right? Yeah.
But I also had, it was okay to just I could finally let go and just really deregulate and relax for the first time as an adult. And gradually, the 12 hours, and even after classes started, it was nowhere near the pace of what I was used to in my medical school work. So it was still, relatively low key, low pace. And I probably slept 12 hours a night for probably about 3 or 4 weeks. And then it was 11 and then 10. And by middle of the semester, I was down to about 8 hours of sleep a night.
Yeah.
So I kind of came back to, I think, some reasonable level of homeostasis.
And I think what most people do, because it's kind of an addiction, right? It's an addiction to the chaos. You want that intensity because now your reward system is built around that thing. A normal person, the reward is going home and getting a good night's sleep. For a cop, for a firefighter, the reward lies in the chaos, right? Mm-hmm. So when I got out of the Navy, I got out December 20th. I had already secured a job that started on December 21st, working for Salesforce. Mm-hmm. I sold my truck and I bought a cargo van, and I spent every night turning it into a surf van because I thought it was going to be my office. I was going to drive it down to the beach every day. I was going to work from there. I started the not-for-profit rehab, the VFW building, local VFW building, made funds, spent all my time there during the day. And it's like the idea of not being in that chaotic environment was suffocating to me. Sitting down at home with my family was just not an option. I couldn't let myself do it. And I think that's what a lot of these folks are experiencing. A lot of these firefighters then go get second jobs.
Right.
They're making
yes, they do.
$250,000 a year, and then they're the next thing, right? So we're teaching people how to really enjoy and understanding how much that taking a break is actually the thing that's going to keep you going longer. It's going to keep cognitive function high, making good decisions, and it's so important, right? Shifting gears a little bit, I wrote down a couple of questions. Earlier, I had the chance to listen to Dr. Frueh address our team after Steve, and you said a couple of things that stood out to me. The first thing I want to ask from that is poor assumptions, right? In terms of cops, firefighters, special operators, we live in a world of these kind of preconceived notions and assumptions by the medical field on you go to any kind of doctor really, or it doesn't just have to be mental health, it can be physical health. And they're making an assumption based off of the general population and not you as a cop, firefighter, special operator. Can you talk about that a little bit?
So there's several issues. One is reference ranges. One is cultural competence. Another is specialties and lanes, staying in lanes. I'll start with reference ranges. In medicine, and this is something that Mark Gordon, a special, I think an innovator in neurotraumatic.
Real quick, he cold outreached to me on LinkedIn, Dr. Gordon.
Oh, yeah?
Had a phone call with me, sent me a couple $100 worth of his supplements for neuroinflammation, and now I take his supplements daily, and no one asked him to do it. He literally on his spare time reaches out to people who have SEAL or whatever in their LinkedIn. He's like, hey, can I send you this stuff because it's going to help you? So anyway, I just want to say that if you see this, Doc, thank you. That was very nice.
He came out to Hawaii last week and spent 2 days with me at my house. We spent 2 days just hanging out and talking.
What a good guy.
And he's written a paper, which, I mean, he's written a thought piece, a review piece that on reference ranges in medicine that resonated with me. I hadn't had quite that same language to put it into, but we take somebody like yourself, and we go, okay, let's figure out if you have low testosterone. We draw your blood, we get a number. Your number is whatever it is. And what do we do with that? We compare it to the reference range of what's so-called normal, healthy. And that range is in medicine, and it depends on the variable, but here we have a range, and it's general population. So we're comparing you to Gen Pop. We're not comparing you to where you were as an 18-year-old. We're not comparing you to other SEALs, soldiers, firefighters. We're assuming you're exactly like every other typical average, statistically average person, man. And there's a problem with that.
Right.
If your testosterone is, say, 310, you're going to be told, oh, it's above 300, you're fine. It's normal, it's healthy.
Right.
And that's them using the reference range. Your testosterone at age 18, we don't know what it was. Reasonable to wonder if it was maybe different from Gen Pop. And so what's the delta from where you started at this, as a young person to where you are now with that? We don't look at it that way. And I mean, it's a problem for all of us. It's not just high risk professionals.
By the way, I nowhere near the op tempo of a very light operational career for myself, right? I did Iraq and Southeast Asia and whatever, not like the days of this incredibly high operational tempo, go all the time.
Dude.
Not my experience, but the reason why I say that
there's
is
no such thing as a normal low op tempo in the SEAL teams.
But when I got out, I had a 190 testosterone score. My estrogen was non-existent, almost unreadable. I was sleeping 3 to 4 hours a night, sometimes less. And I just want to paint that picture for people, because I think sometimes people get caught up in the idea of like an operator where, you need to have done these 20,000 very significant things to have these effects on the brain, body, and mind. And I just want to kind of reassure listeners that that's not the case. You know what I mean? It's not the case. And so if you are feeling, because a lot of people go, well, I'm not that person, right? And I was comparing myself when I got out, right? I had good friends who, were at development group and had been an incredibly high op tempo. And my chief before me, was a, Afghan Fallujah Ramadi guy. So I was comparing myself to the people in my environment. And a lot of young cops and firefighters do the same thing. They look at battalion chiefs, they look at captains, and they go, I'm not even allowed to say anything because I haven't been here 25 years yet. So we really do ourselves a disservice when we start comparing ourselves like that. Comparison is the thief of joy, they say. So sorry to interrupt.
No, that's that's a really legitimate point. And the reference range is a challenge. And that means we're not necessarily identifying people who need to be treated or need to have injuries or impairments addressed. Here's another example of the reference range issue. I have a friend, an operator who mid-40s, doing really, really, really bad. He was at his lowest point. I actually was able to get him into a program in Houston Methodist Hospital for where he came in and he was with us for about four weeks in an intensive outpatient treatment. He wasn't in the hospital. He stayed in a hotel, and they tested his IQ, or they tested his intellectual functioning early on, and his IQ tested out at the 85th percentile compared to Gen Pop. It's high. It's good. This guy's smart. At his low point, as he got better, he started doing well. He came back a year later, doing really well, actually. And he specifically wanted to have his cognitive functioning reassessed for, he was involved in a custody situation. And so he wanted that for to aid his custody situation in a divorce. This time he tested out at the 95 percentile. So his IQ went up 10 percentile points, correlated with him getting better on his hormones, his sleep, everything else, his psychological issues. So one message there, one lesson is healing and hope and recovery are very real and very attainable for many people. Another one is that when you do better in one area, it produces profound benefits into another area. So that's a virtuous cycle as opposed to a vicious cycle. The vicious cycle you were experiencing, and is really common, is if you don't sleep well, sleep is when many of our body processes are being maintained and regulated. We produce testosterone in sleep, and we regulate it in sleep, and it's part of our circadian rhythms. We jack up your sleep, we jack up your circadian sleep cycle. We're going to inevitably affect your hormonal. But having low testosterone actually causes insomnia and makes it hard to get good sleep. So it's a vicious cycle. Poor sleep creates bad hormones creates worse sleep, and it just you spiral downward. So it goes both ways, and the good news is we can enter that at any point and start to turn things around. So the reference range is a real problem in modern medicine. Another one is cultural competence. The field of psychology, social work, psychiatry, we do a lot of talking about cultural competence. Anybody who's training to become a therapist is going to have to take courses in cultural competence. And typically what that means is learning how to work with people from different groups,
right,
and different cultures and different backgrounds. And frequently that's framed around ethnicity, race, gender, sexual orientation, maybe age, maybe a few other things. What we don't do is we don't do cultural competence for high-risk professionals.
Jobs, right.
Very, very unusual to have a course anywhere in your training or any workshop where therapists are taught how to better understand soldier culture or firefighter culture. And so many people have that experience of going in to see a therapist, and the therapist doesn't know what a cop does, and doesn't know what does it mean to be a Green Beret, has never even heard of a pararescueman from the Air Force or a combat controller, doesn't even have the first clue.
So let me tell you what's going on with that right now, because it's a big movement, and I think it could become one of those things that is one of the biggest detriments to what we and other legitimate folks are trying to do. So just like you said, there's this huge movement of operators, cops, firefighters becoming therapists, becoming coaches, doing the work, becoming docs, and it's fantastic. It's kind of running rampant. The negative, what I'm seeing is no one has defined cultural competence in high-risk professions. It's a tagline that hundreds of different therapists are using to gain the business and federal grants from state, federal, whatever, to become these renowned people in these communities. So the question I ask for them is, what makes you culturally competent? How many cops, firefighters do you have to work with before you are deemed a professional in this particular thing. You know, if you're a next door neighbor as a firefighter and you guys talk on the weekends, are you now a culturally competent therapist in firefighting? I don't know. I think in terms of the definition, we are doing it better than anybody else because we have a staff of cops, a staff of firefighters, a staff of special operators, border patrol agents who have gone to learn the lessons they need to learn and get the certifications and then become and do those things. So I think it can become very dangerous, right? The idea of cultural competence if we don't define
100%. And even just more generally, I think it's a horrible mistake for us to be taught to make assumptions about any individual.
Right.
Oh, the color of your skin is this, so therefore everybody with that color skin is X. That's a terrible way to approach it. Now, it's good to know that there are, maybe some generalities. What I always say, in my teaching and my mentorship or supervision that I used to do, the thing I always say is that your best tool as a therapist or a coach is to be humble and curious and to stay in that humble, curious range and listen. You're a Navy SEAL. I've talked with probably more than 100.
I'm a sales guy now.
Navy SEAL. No, you're the SEALs at some levels in your DNA.
I know.
I can't talk to Brendan for an hour and then come to you and say, we don't need to talk. I already know what's going on. Because your life is different. Your circumstances are different. Your genetics are different. Where you came from before service is different. And so cultural competence is a real challenge. But I do think, if I go to what the most simplest point, I think a lot of traditional mental health care makes assumptions. You're a soldier, you're a first responder. Oh, you have PTSD. You automatically have PTSD. I know it.
And you believe it. Right?
And I believe that.
And most people believe it. They go,
and I'm certain of it.
That's what I have. Yeah.
I'm certain of it. And I'm going to tell you that. And why wouldn't you believe me? Because I'm an expert.
Right.
But it's an easy button. It's that big red easy button. Because once I hit that easy button, now I don't have to listen to you anymore. You have PTSD. Here's your medications. There's your therapist who may or may not know anything about you, your background, your culture. It's shocking to me how many therapists who work even in the VA don't know anything about the history of the war.
Right.
Like, how can you work in a VA and not know anything about the war? I have a good friend who was a Marine Raider. Then he was at a tier unit. And then after he separated from service, he earned a doctorate in clinical psychology. And he started working at the VA. And he said in his very beginning of work at the VA, he had to there was like a week-long in-doc process. And he said they had to take there were classes where they had to take cultural competence training in how to work with Hispanic patients, with Black patients, with female patients, with patients with different gender or sexual orientations. Nothing in there was about how to work with a veteran. Nothing in there was about military culture. Nothing in there was about military history.
Right.
That's really sad. And that's part of why traditional mental health care, I think, has really, truly failed high-risk professionals. The people who earn the degrees to do that work, although they're well-meaning, virtually all of them, they bring a lot of assumptions and frankly, ignorance. And I can't tell you how many times I've heard over the years of a soldier or a first responder relaying to me the story of, man, I've been to 5 different therapists, and, the first thing that happens is they tell me I have PTSD before they even learned anything about me. And then if I do start talking or I share just the tip of the iceberg of some of my experiences, they become upset. They become distraught. Sometimes they start crying.
Right.
And then I get up and I walk out and I don't go back. I hear that over and over again.
Right.
And I don't think there's any real self-reflection within a lot of the establishment of the medical and mental health care establishment.
Under the cloud of confidentiality, there's not a whole lot that you can even have to say or report when something like that happens, right? It gets kind of pushed under the rug. I have one last thing that I want to cover before we finish our time here. And it's something that you kind of brushed over, but it really caught my attention during the talk earlier. You mentioned something about a Stanford study with 200 operators, and that you just recently found out it wasn't going to be published or picked up.
By that journal we submitted
Right,
it.
by that journal. And
It's going to be fucking published.
Right. The reason why I wanted to finish on this is because you're in the trenches doing this every single day. You're the work that you've done and continue to do is just so important, and you're not stopping. And so none of us should stop either, right? And you're continuing to try to push the limits. So tell us about that study. Tell us about the people involved and kind of what you think the next steps are, and then we'll kind of wrap it up.
Well, let's go back to 2020. The paper we published in 2020 was really well received and kind of did that viral phenomenon within the community, the grassroots. It was not well received by many of my colleagues and by many of the so-called intellectual scholars, experts in the mental health field. It was viewed as, we don't know what you're talking about, you're way off base. So let's acknowledge that medicine, mental health care, like pretty much every human endeavor, people who've been doing something for a long time, they have their way of doing things. You have people who were part of a movement in the 1970s creating mental health diagnoses of the mental health diagnosis of PTSD, which was added to the psychiatric nomenclature in 1980. And it was a conglomeration of clinicians, researchers, and advocates in the 70s who wanted to create a language to serve domestic violence survivors, sexual assault survivors, and Vietnam veterans. It was really sort of a group that came together for those purposes. They dedicated their lives the last 40, 50 years, since many of those people who were young then are still around. They are editors of the medical journals. They sit on the review panels for federal research grants. They have run the training programs for clinical training programs for ever since. And they run empires. You know, you've got the National Centers for PTSD in the VA, which is congressionally funded. There's 7 or 8 of them around the country. And they're at prestige institutions like Yale, Brown, Stanford. They do research, they do clinical work, they do training, and they are sort of the gatekeepers. And they really are gatekeepers. A lot of the old guard in mental health care fields and medicine, maybe, they don't want to see somebody come along and say, hey, everything you've been doing for 50 years has been off the mark a little bit. We've missed some things. Why weren't we talking about hormones? Why weren't we talking about the role of brain injuries and the fact that you don't have to have a dramatic, documented concussion or a dramatic being blown up in an IED en route Irish to have a TBI? We know now repetitive blast exposures accumulate over time and cause brain injuries. We now know, but we're not pulling it all together. We're keeping things as simple as we possibly can, and we're not acknowledging. Now, if you're a traditionally trained therapist, maybe you also don't want to hear this.
Sure.
Because then you got to learn a whole bunch of new stuff and really change the way you practice and work. So there's been a lot of resistance to quite a bit of this work. And so, myself and many of my fellow travelers have our stories of how we've been kept out of the room. You mentioned your colleague who said it's about getting into the room. We've been kept out of the room. That is slowly starting to change. The Palo Alto VA has a polytrauma program, one of 5 in the VA system nationally, and they've organized things around the operator syndrome framework. And I was not a part of that. They did that on their own.
That's great to hear.
Starting several years ago. The lead psychologist and the research director there is a guy named Shane Adams. And he made sure when they were setting up their their pre and post outcomes assessment, that they were looking at everything in the operator syndrome domain. And he reached out to me. Actually, it was when I was with you in Wisconsin last February. I got this email from this guy. Initially, when I first started reading, I was like, oh God, here we go again. And halfway through, I was like, holy cow, I got to talk to this guy.
That's awesome.
And so we've been in regular communications. They collected data on 200 active duty operators. And they wrote a validation paper I played a small role in it, so I'm a co-author on the paper, empirically validating operator syndrome in active duty operators who were mostly late career stage. And the results come out pretty much exactly as you would expect, or as I would expect.
Right.
We submitted that paper for publication last week. I won't say the name of the journal, but it's a journal that specializes in military medicine. And that's in the title of it. It's in some form. And it was rejected this morning. We got a rejection letter from the editor. That happens. No harm, no foul. This is just what happens. It's part of the game. What I tell young scientists is, well, we talk about all the home runs that Babe Ruth and Hank Aaron and Willie Mays hit. We don't talk about their strikeouts.
Right.
It's the same in medicine. I have over 300 publications, but I have probably a couple hundred rejections as well. You submit to one journal, you get the review. If the review is helpful, you revise it. And if they reject it, you go to another journal with it.
Why do you think they rejected it?
I'll tell you what their stated reason was. The editor did not send it out for peer review. So it didn't go to any reviewers as far as I can tell. It was the editor who made a decision, and that's allowable. It's rare, it's unusual, but it does happen. And what he said to Shane in his message was, it's not accepted. We're not going to take this. It's a well done study. Methodologically, the data look good, are tight. It just isn't important enough.
Right.
Just not important. We don't care. We don't want to hear this. Doesn't surprise me. And since I didn't speak to the editor, I won't. There may be perfectly valid reasons. I don't know, but it is so. Shane, I think, was disappointed, and I said to him, "This is to be expected. We're probably going to have to go through multiple journals before we find an editor and reviewers who, with an open mind, are really considering this work." Can I share a quote from Max Planck?
Yes, please. That was going to be the last thing I asked you to do.
Yeah. So
can you kind of readdress real quick what the quote is? Yeah.
So Max Planck was a German theoretical physicist who founded quantum theory in the, I'm not even sure, 40s, 50s. And I'm looking at my phone because I want to get the quote exactly right. But there was a lot of resistance to the concept of quantum theory. So this is his quote, and it was in a book that he wrote. Quote, "A new scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it." Now, we could summarize that by saying that science advances one funeral at a time. And right now I'm not wishing death on any of my colleagues at all, but some of them will be passing away. Some of them will be retiring in the next few years. So, at a certain point, I'm very optimistic that the next 5-10 years are going to see a lot of change, and sharp performance really is, as I see it, is going to be a huge part of that. And the idea, the concept of peer coaching is disruptive to the mental health care industry. It's a paradigm shift. And I believe it's a necessary, needed, important paradigm shift for many in our society. I could see a future where many people, not just high-risk professionals, air traffic controllers, ER nurses and docs, people who have very fast-paced, high-tempo, stressful jobs, maybe college students who are lost and don't know where to go. Are they benefiting from years of psychotherapy where they go in and they chit-chat about their day and their frustrations and vent and get their feelings validated? I don't think so. I don't think that that's very useful for many people. Coaching with specific goals and accountability and compassion from somebody who's kind of been in the space, lived through it themselves. I think that's potentially the paradigm shift of the future.
I don't think you could say anything more important than that. I think people really need to hear that. I so appreciate your time. I appreciate your friendship. It's really humbled to be able to learn from you and hear your messages, and then be able to take the framework of something that you created and push it out to a community I care deeply about. So truly, thank you so much, Doc. It's been a pleasure.
You're thanking me and you're expressing, that it's humbling. I say the same thing back to you and to your community. It's humbling for me. It's a privilege for me to have the opportunity to work with the people I've been able to work with. And it's changed me as a person. It's made me a better person. It's been apart from my marriage and my family and my cats, it's right there. It's right there among the best part of my life ever. I couldn't be more blessed.
Right. Thank you so much. And if you're a leading professional in anything out there and you think that you have a value add, please contact us. We want you on the team. This is going to be something that continues to grow into a true paradigm shift, something that's going to change hundreds of thousands and then millions of lives. And we're doing it one person at a time, and we're doing it right. So thank you so much, and hope everybody has a great day.